I've been working in primary care for many years. You just heard this in my bio. First, I was a clinic coordinator, and then I was a director of health services, then I was the executive director at Planned Parenthood. It's a community health center for youth. And almost 6 years ago, I had the privilege of stepping into the role that I'm at now at the Alliance for Healthier Communities. For those that don't know, we are a provincial association that represents comprehensive, community-governed primary health care organizations. And we have members right across Ontario. This includes nurse practitioner-led clinics, community health centers, Indigenous primary health care organizations, community family health teams. We have a FO, we have a FIT, we have a hospital. We got a whole bunch of folks that are our members. And like any provincial association, we advocate for resources, provide education, and support our members. But we've also been asked to play a second and more critical role to champion health equity across the system. Now, you know that I've been in the sector for more than 20 years, kind of a long time, way more than 20 years. And in this time, I have seen wave after wave of primary care reform, primary care transformation, primary care innovation, primary care insert word that you want to put here that means something new and something exciting. And I've seen it come and I've seen it quickly go. But this moment feels different. This is the first time I've seen this level of focus on primary care. The first time that I've seen record level investments going directly into team-based care. The first time anywhere in Canada have we ever seen legislation that's been created and dedicated to primary care. It's exciting. It's validating after so many years. And it is also deeply, profoundly terrifying. It's terrifying because I'm not sure we're going to get it right. Now, who am I to say that? There are incredibly smart, big-brained, as Cliff would say, capable people across government, at the Ministry of Health, within Ontario Health, working hard to plan and deliver improvements at a scale that we have never seen before. And much of this is happening under the leadership of Dr. Jane Philpott, who is absolutely the right person for this moment, and who has accomplished an extraordinary amount in just a year and a half. It's hard to believe, just a year and a half. Let's think about what she's already achieved. Convincing government to invest in $3.4 million into primary care. Embedding the importance of primary care into legislation, setting out what every Ontarian can expect from the primary care system, which includes an annual public reporting to see how government is doing against that legislation. Driving towards a more connected system, moving from a very fragmented electronic medical health record system where 15,000 primary care docs have all gone out and bought their own EMR and using them the way that they want to use them, that is not connected, not standardized, and pulling that into having an integrated, interoperable primary healthcare medical record system that can speak to one another but also speak to other parts of the health system. These are not small things. These are system-shaping changes. So let me be clear. This is not a critique of the work, and it's certainly not a critique of the leadership. What I'm saying is this. We have a once-in-a-generation opportunity in front of us, and I'm still terrified. Terrified that we won't get it right. Terrified that even with all this progress, with all this investment, we will most definitely continue to leave people behind. Because the goals we've set, while important, are also political. They're measurable, countable, trackable, and that's not a bad thing. But when the goal is something like 100% of Ontarians with a health card are attached to primary care by 2029, there is very little room for nuance, very little room for complexity, and very little room to take the time it actually takes to build a system that works for everyone. Let me tell you about my best friend. I've known her since we were 3 years old. She is a personal support worker who works in a long-term care home. She also works in a community health center, not by my doing, that was just a happy coincidence, doing home care. And on top of that, she is the deputy mayor and councillor for her very small, very, very rural Ontario hometown. She's quite simply my hero. And by every official definition, she is attached to primary care. She has an ongoing, documented relationship with a physician in her small rural town. But this is what it looks like for her in practice. She books her next appointment 3 months in advance, every single time, whether she needs it or not. Her next appointment is in June, because she's my best friend, I know what she's doing. She's got a doctor's appointment in June, and after that visit, she'll book one for the fall. Because if she doesn't, she knows she won't be able to get in. If she waits until she actually needs care, she has to call in at 4:30 every day to see if there's a cancellation for the next day. She's tried repeatedly, and it's never ever worked. So what are her options? She goes to the emergency room, or she has to drive well over an hour to go to a walk-in clinic where they actually might not still be seeing her because it's so jam-packed. So yes, she's attached, but does she have access? Does she experience equity? Her story highlights two critical gaps in our system: access and equity. And her story is one of privilege. She was born in Canada. She is a white woman who speaks English. She's heterosexual. She has a home. She has a health card. And she knows how to navigate the system because she's a part of it. So think about all the people who don't have any or all of those privileges. This is why I believe deeply that if an Ontario is going to build a strong primary healthcare system, it must stand on a three-legged stool: attachment, access, and equity. We cannot build a stable system on one leg or even two. Attachment, access, and equity are not initiatives, they are load-bearing. Right now, one of those legs, attachment, is getting most of the attention. Yet without equity, attachment does not translate into better health outcomes. It simply redistributes access to those already best positioned to receive it. And if we're not careful, we risk building a system that looks like it's successful on paper, but fails people in practice. And we see the consequences of this most clearly in communities that have been historically oppressed and underserved. For African, Black, Caribbean communities, for example, we know the data tells us a consistent story: higher unmet health needs, greater barriers to culturally appropriate care, and poorer health experiences in the system. And yet these are not new problems. What we have been missing is not awareness. It's been the willingness to design primary care in a way that actually responds to those realities. Because attachment alone does not improve mental health, physical health outcomes, especially if the care that people are attached to does not reflect their lived experience, their culture, or their needs. So this is when equity stops becoming an aspiration and becomes a design requirement. So what does it look like if we get all three legs of the stool right? One answer is the neighborhood health home. It's an approach developed by the Alliance, grounded in real-world experiences of our members. This approach is fully aligned with the goals of the Primary Care Action Plan. Yes, it delivers on attachment, but it also ensures access, and it is intentionally designed to advance equity. And importantly, it's not a theoretical model. It's not a vision for the future. This is not starting from scratch. Community health centers have been doing this work for decades, integrating care, advancing equity, and partnering with communities. The neighborhood health home builds on that foundation and scales it. It's already being implemented in different contexts right now across Ontario, and here's what makes it different. Neighborhood health homes are rooted in place. They serve a defined geographic community or priority population, so care is organized around real people's lives. And I'm not talking at the local CHC level or local team level, I'm talking at a regional level. We've heard Dr. Philpott talk about mimicking the school board system to healthcare. This is that, but we also know that the school board system isn't an equitable system. People have better or worse experiences. So this neighborhood health home approach is to try and even that out and ensure that equity is still considered. So every person has barrier-free access to an interprofessional team. So not just nurses and nurse practitioners or physicians, but a full team along with health promotion and community supports. care is designed not for communities, but designed with them. So community members are involved in governance, in decision-making, and co-design. And critically, the model builds on what already exists. So, and this is not about CHCs are the best model. It's not. But what it is about is connecting all of the primary care. And we sometimes, Jen often calls it an alphabet soup. The FITs, the FIGs, the FOs, the FINs, the solo practice physicians, the CHCs, the nurse practitioner-led clinics, the Indigenous primary healthcare organizations, you name it. What it does is it brings them all together in a region, and it creates the conditions for that shift by bringing providers and asking a simple, powerful question. What are you good at? What can you offer? And what do you need to do it well? So it becomes a hub and spoke model. It's about understanding and leveraging the assets that already exist in communities, and it must include centralized intake. So people are matched to the right care at the right time at the right place. So if you have a region, and that region has a CHC with a particular focus, or it has a Chinese-speaking solo practice physician, or it has a community family health team that does gender-affirming care, or it has family docs that are happy to see the walking well. It's about distributing their population and matching them to the right level of care that they need. It ensures that the trust that is built with communities remains, that specialized health equity-focused care is provided to the people that require it. And at the center of it, we call the hub. Now, Jen and I totally regret calling it a hub because everybody's like, you need a building, you need a big thing. And we're like, no, we don't need a building. It's not fancy. It's not something we need to build. It's a team, and it's not a location. It's a team with a mandate. A mandate to address the social determinants of health and to support other primary care teams and clinicians. And ideally, a mandate grounded in community governance. So the response reflects what people actually need. Most often, this is a community health center, but many teams are acting as hubs for their spokes across Ontario. And the spokes can be those number of things, whatever they might be. There's also where the link workers play a critical role. And link workers connect the clinical world with the social and community world. They allow physicians and nurse practitioners to do what they do best, which is medical care. They allow the people to get, not allow, they ensure people get support for the real life issues that shape their health, because health, and you know this, isn't just about a diagnosis. It's about whether you can afford food, if you have transportation, if you're socially connected, whether you have access to the internet, or whether you even feel a sense of belonging to your community. Link workers practice what is known as social prescribing. We call them link workers because social prescribing doesn't have a lot of appetite for government. Link workers do. They spend time with people, listening, understanding, connecting, and they shift the conversation from what's the matter with you to what matters to you. And the impact of this approach is measurable. Jen and her team have done research and evaluation, and we have seen when somebody has access to a link worker within their primary healthcare team, there's a 14% decrease in emergency room visits, a 20% reduction in overall health system costs, and a 40% decrease in general physician visits. So if you think about, if we had all of the complex folks that need to be working with a link worker and we were to provide them that access, how many people we'd be able to attach to the system if we had a 40% decrease in general family physician visits. And link workers don't just support the people that have been referred to them. Very often, they are working in community and often are the conduit to people and groups of folks that are unattached and frankly don't see the need to become attached. There's assumption, and I would say a misconception, that everybody in Ontario is just waiting patiently to be attached to primary care. There are many communities, for very important reasons, that don't trust the health system or don't see the need to have a primary care provider or don't even know what a primary care provider is. And so link workers can build that trust. They can provide information, and they can talk about what it might mean for somebody to have an ongoing, documented, longitudinal relationship with a physician or a nurse practitioner. So how does the neighborhood health home actually deliver on access? Because if it doesn't, we end up with more people like my friend, technically attached but waiting, still calling at 4:30 and still falling through the cracks. It addresses access in 3 fundamental ways. First, by ensuring every member of the team is working to their full scope of practice. Because my friend doesn't always need to see a doctor. She could see a member of a team. And if that doctor working in isolation does not have a team, the hub can provide the team for that family doctor's patients. We have highly trained professionals, nurses, nurse practitioners, social workers, dietitians, pharmacists, who are often too restrained by outdated roles and structures. When people work to full scope, access doesn't just improve, it expands. Second, by making primary care a place where people want to work and can afford to stay. Because access is not just about systems, it's about people. And if it's my friend can't get an appointment, it's not because she isn't attached, it's because there's not enough providers, and many of them are stretched too thin. If we want team-based care and primary care to be successful in Ontario, we need to recruit and retain providers by offering competitive wages, stable and meaningful work. Because you cannot build access on burnout, and you cannot sustain it on goodwill alone. And third, by embracing what we call a learning health system, one that uses data not years later, but in real time, to understand what's working, what's not, and where the gaps are. We don't just assume people like my friend have access. We can actually see whether they do, and if they don't, we can fix it. And we can share those learnings across teams, across organizations, across communities, because no single team should have to solve these challenges alone. This is how access becomes real, not theoretical, not assumed. The neighborhood health home approach is not just better care, it's smarter care, and it's completely scalable. It does not require a change in governments. For so long, we've been talking about the governance of primary care. We've been talking about the governance of OHTs. We've been talking about the governance of Ontario health teams, of primary care networks. Primary care networks play a very important role in the neighborhood health home, but none of this is about governance and not about changing payment models. And it doesn't even require additional funding beyond the primary care funding that is available. It does, however, require alignment, it requires trust, and it requires a willingness to do things differently. And we are already seeing that it works. But it takes time. And let's be honest, we've spent the last 50 years pitting primary care against one another in a rewarding competition. And now we're asking people to collaborate with one another. And that's not a small shift, that's deep change management. But we're seeing it work on the ground. So as we move forward, as we invest billions, as we legislate expectations, and we redesign the system, we have a choice. We can build for speed, and we can build for strength and better health outcomes. We can count how many people are attached, but we can also ensure that when they are attached, they can actually access care, and that the care will work for them because it has an equity lens. Because if we don't get all 3 legs of the stool right, attachment, access, and equity, we will build something that looks stable but isn't, and we can't afford that. This is our moment. We need researchers, we need students, we need service providers, we need all of you in this room to shape this trajectory that we are on. And so let's not build just a bigger system, let's build a better one. Thank you.